builder of two healthcare companies before running a federal innovation policy, a key architect behind kidney care reform, which I think is very unknown about our guest here today. And to top it off, Forbes 30 under 30, receiving this when he was 26 years of age for health policy innovation. Please, everybody that's listening, give a warm welcome to Abe Sutton, the Director of CMMI and Deputy Administrator of CMS. Abe, welcome to our show.
Thank you for having me on. It's really a privilege to join you today.
This is fantastic, Abe. I've been following a lot of your work of recent, and the cross-pollination of digital population health and a large part of how we put together a stronger budget for healthcare in the United States for decades into the future. And before we get into a lot of your current work, we love to talk about the person behind the titles. And you've held a very interesting role of recent, leading innovation at Medicare, Medicaid Services, CMS, under the Innovation Center, CMMI, for the US government here. And going back, and I led in with a couple examples of where you've come from. Honest Health, I thought, was a very big milestone in what you had done in your early career. But did you ever think you'd go into healthcare reform and developing new payment models? Was this ever on the roadmap for you personally?
Well, I was always interested in government and what government can do to move markets, to make the right incentive structures up, to help people get better, more affordable care. I think this probably stems from over a period of years watching my dad coordinate the care for my grandmother. My grandmother had Parkinson's disease, and Parkinson's as a neurological condition is something that can interact with the pharmaceutical products that you might be put on to deal with cardiac issues. And so seeing the confusion as we need to coordinate what is good for your heart with what is good for other conditions that you have, and how hard it was for my dad to navigate that, and how he had to really spend years of his life coordinating her care. And that became such a central focus for him. It became apparent to me that there's something broken in how we're approaching this and how we ask families to approach the coordination of care for their loved ones. There's no one who is there as an advocate for you. There's no one who's taking the perspective of what is right for you. And I make that sweeping statement, but sometimes there is. Sometimes a family member could step up and take that on and have the expertise, but too often it's not the case. And our system fundamentally is not geared towards providing that for people, to making it easy to navigate our healthcare system and know how to access and afford care. And that's something that just jumped out at me as something that we needed to change. That's something that if I could play a small role in making a difference on for families like mine, it would be meaningful. So that's what motivated me in things I did in the private sector. It's what motivates me today as well. And it's what motivates a lot of my team here at the Innovation Center. Our mission is to make care more affordable for people and to make our healthcare system work better. And so the opportunity to be part of this team and get to work on that is a privilege every single day.
A privilege and a heavy weight, I'm sure, for yourself and your team. I think what is so fascinating about what you shared in a couple parts there, Abe, is that yourself and your team have come from different segments across the healthcare ecosystem and from different angles as well. And I'm curious, with what you noted in your family experience, which a lot of people have that pulling effect to do something more in their career in the healthcare ecosystem. And I think a lot of people continue to admire that part of your story and can identify with it. That, in combination with your work in building healthcare technology organizations, has that been a secret sauce for you to be able to build things quite quickly and find the right path to deliver on the mission that you just noted?
The Innovation Center is a young organization. And I say that in a couple of senses. One, by the standards of a government agency or a component of a government agency, being around for 15, 16 years is not a long track record. We're new. fresher thinking. And I know folks from the more health tech universe are thinking, wow, that's an ancient Goliath. In some universes, all the AI companies didn't exist on that time period. But by government parlance, that counts as new. But also, many people are drawn into a stint in federal service in the Innovation Center because it has the ability to move fast, push things forward. And so also by virtue of just years of tenure of government experience, our workforce combines the stalwarts of government service with people who could bring fresh perspective, new ideas and energy, and combine them to produce something pretty impactful. And so understanding how the models that we've set up have played out, having participated in partnership with physicians in our models, is something that gave me some perspective that you just couldn't have had if you were the first director of the Innovation Center, because there were no models to participate in.
Exactly.
And so some of the kinks, I'll call out data access. I'll call out information on who is attributed to you, the payment timeline and how that makes it harder to underwrite investment. I just had experience and pain points with some of these aspects, which gave me a different perspective coming in. I also was aware of stroke of the pen risk and how if the government makes a radical change that's not foreshadowed, it really undermines confidence and it makes it harder to reach and support patients. You need to rework your staffing arrangements. And that's like really hard just as an operator to experience that. So that gave me a grounding in how we should operate. It also gave me a grounding in some of the problems in our healthcare system and how the Innovation Center might be able to help address them. But the real secret sauce that I will call out is the fact that there is an exceptional team of doers in the Innovation Center who both want to think through what their policy should be, but also really want to engage and operate and run things the right way and set them up for smooth supports for participants.
I like how you put all that together, Abe, because I see it as a large butterfly effect that a lot of healthcare technology firms, others that sell directly into health plans, healthcare systems, biopharma, et cetera, don't realize how stitched together and fragile our healthcare ecosystem truly is. And when one thing changes, it can have a wave of effect elsewhere. And having a team that is able to think through thoughtfully a policy and knowing that butterfly effect can occur, I think is a rare thing to have. And in a young organization, like you mentioned, only 16 years in comparison, that might be a very long time for other organizations, but your model is very different in how you operate. So I wanted to thank you for how you structured that. And one of the biggest things that's been running at an increased clip in terms of provider network contracting is value-based care methodologies. Back in my day with Cigna, it was after the second term of Obama, the 50-90 rule came out. Everyone was pushing narrow network designs, but giving little to the provider side of our community from the payer side. And I've seen a lot of different value-based models launched over the last decade. Not a lot of them have delivered on the promise that was in the near term. And I'm curious from your perspective, what distinguishes a model that can truly change care delivery versus those in the past that have struggled to do so, that have just maybe pushed risk or capitation models at that?
It's a great question, because I think we're forced to grapple with 15 years of history, what's worked, what has not, and learn from that experience. It depends somewhat on what levers people have and what incentives you set up for them. If you give someone the right incentive and they have a lever to pull, they will pull it. Or somebody will come in and out-operate them and find a way to pull it. But you need both sides of that coin. You need the incentive, and then you need a clear lever to get there. The most clean way to describe, I think, the last decade and a half in accountable care arrangements is that there were other aspects that were easier to pull on that would enable people to succeed. And we disincentivize some of the real levers in improving clinical care and improving access in our healthcare system. So to make this specific, it was easier to go through and think through how you combine the doctor's identity number with the tax ID of the group in order to optimize the configuration of who's in your organization because of how we combined historic costs in your region with your historic costs as your group to get at your, what we call benchmark or expected spend. It was easier to optimize around let me be in this model and not that model, and opt in for that episode. And oh, they didn't include this code, so let me increase utilization on that code and hold down here for the things included in the episode. It was easier to optimize, and I'll say it, on risk adjustment, on investing in documenting the risk, but not necessarily treating it and helping people live healthier lives.
Yes.
All those things are not evil. Like, I just want to be upfront. Like, we incentivized this behavior, and therefore people did this behavior.
Yes.
We are now changing the incentives. We're not going to reward you in the same way. We're putting more thought in our design. You are going to have to do it as a practice if you want to come into an ACO, rather than a doctor by doctor level decision anymore. We've gone through and removed some of those aspects, but we've also tried to be really intentional about giving a clear way to win and giving levers that are tied to improving care delivery. So what do I mean by that? We actually disincentivize holding down costs by improving clinical care, because if the cost fell, we would rebase you in a way that in a few years, you actually would not be able to be in an accountable care organization. It's just like we say, oh, you used to cost $100. You held it down to $90. We now expect next year the patient to cost $90. But how far can you push down? How fast can the hamster wheel get at a point where it just becomes unsustainable? And you step off and say, I'm actually going to just bill fee for service and charge for each thing I do, because this is just getting faster and faster and faster as you push down on me.
Yes.
We just gave a 10-year model in lead without rebasing. And we also adjusted it to account for as you've succeeded in the past and not just tie you to what the costs were last year. So we now have a sustainable financing mechanism in place where you can improve clinical care and coordinate with people and take out costs. But we've also tried to make it easier to leverage some of the new promising tools that are available to help reach people, coordinate their care, and improve their health outcomes. And I'm talking, of course, about use of new technologies to support your patients, whether that's things that help extend an individual physician so that you don't actually need to be referred out to see a specialist, because as part of this visit, I can help you address this thing and understand how to address it. I'm relying on a tool and a database, and you don't need to have a 4-week break before we can get you into that specialist. Or I can make a resource available to you between your visits to help support you so that you don't need to show up in the emergency department and you don't need to just wait and sit on that question and maybe delay needed care that, frankly, we need to make sure you get access to because we'll flag it and catch it sooner. These are things that if you're paid off of a fee schedule, you will not adopt as a healthcare system, meaning a hospital system. It's just not economical because we don't incentivize it. Even if you know it's the right thing and want to do it, it's a really tough pill to swallow to say, I should empty out my hospital to make that work, because you just can't square the math and you need to serve the community that you're there for. But now, if you sign up for the lead model, you actually could just deliver care the way you want to, reach people, use every tool, take out costs, stretch your resources to serve more people. And that improves access in our healthcare system. That's going to make care more affordable. And it's going to let our healthcare systems win financially. Independent practices win financially by doing the right thing. And so the combination of the incentive to act and the tools to act is what I think are going to set up the models we are revealing now for success.
I love that you broke this down from a funding perspective to really helping physicians have more of a spread offense in the tools they have available to drive better health outcomes down the field, in the analogy I'm making here in this moment. And Abe, I think it's so difficult what you're attempting to do because we've created this behavior unintentionally of how services are reimbursed, and it stops there in most part. And it's different across hospital-owned physician groups, private practices, large IDNs, et cetera. Everyone has a different culture of health and business care delivery. But you're tackling a behemoth. And I'm so thankful that you're being so thoughtful with your team, but also steadfast in terms of the pace that you're thinking about here. One thing that I thought about as soon as you were talking about making things more affordable, Paul Markovich, the president of Blue Cross Blue Shield California, recently noted to Congress about putting us on a budget and how we can create a thoughtful ceiling of where we need to stay within in terms of spend. As you've seen over the past decades, the increasing spend, now we're over 5 trillion on an annual basis, is what it was reported last year in an aggregate figure. Is that budget philosophy something that's just naturally woven in to the models that a lot of your team are thinking through, and maybe inherently, or is it still really focused on having the outcomes there and the reach there, spreading the resources out for physician groups like you had mentioned?
I think Paul makes a really good point, right? That $5 trillion is something that's a real burden on an American family. If I think about the average retiree, you're entering Medicare, in order to sustainably finance the different costs that you'll need to pay out of pocket over your expected time as a beneficiary enrolled in Medicare, one estimate I saw recently said you really need, with a reasonable expectation of what costs could emerge, something around $500,000.
Wow.
You mentioned we're at around 18% of GDP, just back-ending the math from the dollar figures. But by 2033, we're going to be at above 20% with our current pace of growth. Right? We've seen other parts of the economy over time become more productive and help use the same resources to serve more people. And that makes care more affordable for people, so that the average family is not delaying care, which, 26% of American families say that in the last 4 years, they actually delayed necessary surgery or medical care due to cost. And 18% of adults said that they actually chose not to switch jobs in the last 4 years because of a fear of what would happen and the medical costs and the expenses they might have. If we could look at this and say, let's make it more affordable for people, let's lower what we spend as a country on healthcare, and it becomes a smaller share of that retiree's budget, a smaller share of the average family's budget. So it stops crowding out spend on other family priorities, whether it's growing your family, family formation, whatever the priority is, that would be a good thing. Making care more affordable is not just about every individual American. It's about the premium that you don't see that your employer is paying as well that's weighing on you, and the premium that a state is paying for a Medicaid beneficiary, or that we pay federally, of course, for a Medicare beneficiary. So I agree with Paul. We need to confront that. I think the best way to confront that is setting up the right ways to care and giving people in the healthcare system the way to care for people. So let me highlight one of our recent models, the access model.
Yes.
And access is really about digital therapeutics. So think of an app that you might use to help, you stay calm, help you feel at peace and in balance and in rest with your behavioral health, just aspects of your care, if you're somebody who can benefit from that, or help somebody engage in the care of a chronic condition. So let's think of someone with kidney disease or diabetes. We set up a structure where we are going to pay for Medicare beneficiaries in original Medicare to come in and engage with these apps, with Medicare covering the cost. And as people are engaged and see improvements on outcomes, like do your A1C levels drop from the base measurement to what your measurement is a year from now? And can we maintain that in future years? We should pay for that.
Yes.
Why? Because it's the right thing and it'll help people get better results, but it'll also make care more affordable for them and the Medicare program by avoiding unnecessary utilization, by keeping people healthier longer. Like, these things align is the point I'm trying to make. And I agree with Paul, and I think Paul agrees with me. I'll note that Blue Cross California came in on our access model in what we call the Access Payer Pledge. And we have 25% of the Blues across the country, all of the major nationals within Medicare. We've got major Medicaid and commercial players who have come on board to say by 1/1/28, a year and a half after access goes live for original Medicare beneficiaries, we will have launched a similar outcome-aligned payment approach, because we believe this is the right way to set up an incentive structure where this new technology and the tools that it enables are adopted in ways that improve outcomes for people while being paid something that will hold down spend overall for our healthcare system.
And I love the outlook that you gave us in terms of time, access formally launching this summer, and the pledge that has been signed, but all of those large national Blue Cross Blue Shield entities as well is extremely motivating. I think I saw Centene on there, Sarah London, Nathan Lansbaum raising their hands. I think you have large swaths of people that are getting covered by these insurers, these payers that truly believe in a non-CPT code based reimbursement methodology, which actually one little nuance that maybe folks might not know about access that I'm very excited about, because that is breaking that behavior that you had mentioned that has woven into how things are just unaffordable, unaccessible these days. And Abe, I think the most exciting thing about the access model, and I know you would agree with this, it is the digital population health play. And I think about these big players that have turned their device into biosignals like Aura Ring and Ricky Bloomfield and what they're doing there with their device for women's health and seniors health, and even Calm and California there with David Coe and what they're thinking about in terms of mental health, better sleep, etc. Is this their big moment to step on stage and see what their solutions can do in a measurable way over time for the senior cardio, kidney metabolic population and beyond?
Well, I hope it is. We attempted, Brian, to set up something that can work. So those players who you named could come in, and others who want to start something could come in as well. It's a pretty open playing field, and the FDA has worked closely with us in giving a path for market access for those where there might be regulatory market access barriers as well. But Medicare beneficiaries have never had access to this in a way that the government pays for it. Some people have paid cash and just, oh, I'll pay out of pocket for this. I get value for that. But how impactful would it be if when building a direct-to-consumer application in healthcare, you didn't only think about the segment that is willing to pay cash, you thought about the most vulnerable in our society on Medicaid, or our retiree population on Medicare, and how to serve them, how to reach our nation's seniors and give them supports because they could benefit from this. Mm-hmm. And I'm hoping that people come forward and see this as a path where they can make a difference, and that they also adopt to the moment of say, let's make it an agentic approach. Let's recognize that Medicare is willing to engage here in a way where it is structured where we are giving more than we are getting by engaging. We are helping these seniors improve on real outcomes, and by doing so, holding down expected spend for those seniors and for the Medicare Trust Fund. And we pegged our payment rates below what people are getting in the commercial market today, partially because our sales cycle is easier. You don't have to go in. There's no start with the pilot program. You're starting with this program where we are paying. We lay out exact criteria and we take everyone who qualifies, and it really is a direct-to-consumer relationship. Or work with a physician group to help engage their patients if it's helpful for them. And we really tried to give an incentive for the healthcare system to adopt this and made it easy. It doesn't count against benchmarks for the accountable care organizations. But depending on track, we pegged at somewhere between a third and a fifth of what we were seeing in the market on commercial arrangements. Now, we estimate if we look at what it would cost to build this, and I literally sat down with Jacob Schiff, who is the Chief AI and Technology Officer of the Innovation Center and previously was CEO of a health tech startup. And we sat down and was like, all right, if we were going to pitch to a venture capitalist, how would we explain our cost structure? If we were going to do this, what would our costs be? And we broke down not the cost of development, if any of these players who have an application for the commercial market already, or who will pitch to VCs on the ultimate sustained business once they get to millions of lives, but on a per patient, what is the cost of running the LLM? What are the factors that lead into this? And we built up bottom up. We put margin on there. There is room. And we said, we'll pay this. And now we're not micromanaging exactly what you do. We're not locking you into the technology of today because we recognize that 6 months from now, tech will look very different.
Yes.
But we're willing to pay something that should work for people to come in. And we know based off where we see costs being driven by these outcomes and where commercial plans have been willing to pay for engagement with some of these solutions, that this is creating a real win opportunity for the taxpayer and beneficiaries where what they pay will go down.
And I think from a macroeconomic standpoint, that is so solid and surface level. I know there's been reactions to the provider rates, but they're thinking, in my perspective, very short term. If any one of, I'd say, my friends across the ecosystem hear this part of our conversation, Samsung Health, beyond, I think these folks need to step up in a big way and provide value. It's the long tail to this that will increasingly lower costs and increasingly give access to healthcare services through prescriptive technologies like you're discussing, Abe. And that's the way of the future. It needs to be adopted now. And this is also a conversation for other vendors. Enter access now because it is the first iteration of the continued way things will be paid for and how people will get access to things. It's the new way that patients will be talking to their providers and vice versa. That's my personal opinion on it, just studying it for the last several months here, Abe. And I'd love to take a little bit of a look into the future. So say we go about 10 years fast forward here, and we have a next generation to this model of value-based innovation. Is it going to be more ready to adopt by specialty care? I'm thinking like rare disease, rare orphan disease, oncology, behavioral health, home-based care. Well, a little bit of my kind of focus right now, things happening in the home. What's the next subsegment that's going to be ready to adopt more wholly a value-based care innovation that access will continue to flush out, as an example?
It's a great question. I mean, what we've thought about today is what are the models we need to do to make the healthcare system better a decade from now? What are the things that if we test, we prove that they work and we certify them and we expand them to run nationwide perpetually as part of the Medicare program or as part of Medicaid, that we'd want to be pillars of how healthcare is delivered in this country? Access is part of that. The lead model for the incentives are part of that. A lot of the drug models that we've done to make investment predictable in that space while increasing the affordability of drugs for the American people get at that as well. We've tried to pick out the gaps in our system. As we look at, there are some things the portfolio gets at really well. We have a lot in the Medicaid space that is quite thoughtfully constructed right now and is going to push forward in partnership with states. We've had a good number of specialty models in the past that are episodic in nature that have been well-intentioned and some that are really well-structured. We've had some that, frankly, have produced savings if you look at the evaluation report and improved quality. Like they're really hitting the target. That's really reassuring to see. That's what you want to see when you set out to run experiments here in the Innovation Center. We're not really approaching it as let's solve this particular niche thing here, niche thing there. We're more thinking what are the pillars that build up that could become the foundations of the system of the future. The world will change in the next decade. We will see how this play out. We will monitor it. And we are aware that the world will change in the next decade. The concept of the specialist and the subspecialist that really, really took off in the 20th century, is that the right model today when actually an individual physician with a generalist training can navigate a lot more of the knowledge base with different tools at their hands? Does that address the provider shortage in rural America? Because one physician can be confident speaking to a wider array of medical subfields than they previously should have been comfortable speaking to. I don't know how this will evolve. We're going to continue to look and see as trends change in healthcare. We're going to continue to engage with people pushing forward from the academic setting, in private practice, what they're doing, from people who are looking to innovate here. And we're going to try and build the on-ramps to a system where care can be delivered in a more affordable manner.
I like how you noted the rural side of the vision here as well. I think a lot of challenges have been seen from folks that have wanted to play in that space. I can talk about that from Best Buy Health perspective. I think what Kaiser is attempting to do with their rural health portfolio, and Geisinger being the epicenter of that, is a true testament that it's difficult when you don't have enough to be able to serve complex needs that are different subcultures of health and literacy in particular, and how they drive a lot of cost of care and how also they have low rates of quality of life and also length of life too that affects local economies tremendously. So there is a component there that I see that's going to be driven out through a lot of your work here, Abe. So a couple of questions to bring us home. And I think this is a newer take on the way we like to inform our audience. So I'll run through these questions and also get maybe a look back from you as well here. So one healthcare myth you wish policymakers would stop believing, what would that be?
Been told about the complexity of the system And people sometimes accept that at face value instead of digging in and clicking and seeing, all right, well, what is the incentive and why is it that we have a shortage here? Oh, we regulate the supply and you actually cannot compete in that space because of certificate of need laws or supply side restrictions through scope of practice. And, oh, we don't allow you to do this across state lines, so you actually cannot serve. And that's why there's no one reaching the patient population. We get so hung up on there is a shortage that is a natural equilibrium and we need to pay more to solve the issue. But if we double click and look past the complexity, we might see that we are causing an issue and distorting the market, and that maybe we could just clean that up and people will have more access and care will be more affordable.
Fascinating. I don't think a lot of people would have seen that coming out of your brain right now. That's a very good nugget of insight. Okay, one more, and then we can begin to get to a close here, Abe. One innovation you believe will dramatically reshape care in the next decade? Something that maybe is on the cusp, but it's not a real thing. What would that be?
I'm not going to say it's not a real thing because it's already a thing. But if you look at the FDA's pipeline of cell and gene therapies, there is a ton packed in there that is going to transform care for people with rare diseases, for people with broader array of diseases. Like, I am just so optimistic as I look at what is down the pipeline. And I spend my time thinking through, like, well, how do we pay for this and figuring that out? But the promise that our grandkids might live longer than we are able to, and that the health span for people is going to be extended has never been more real than it seems today. And so I am incredibly optimistic.
I love that. A shout out to Abe Bhatt, who's a big part of the American College Cardiology and of course, also FDA advisor. So I just always have to call out those amazing folks that are touching some of those crazy, crazy things that will benefit our population in the future. Abe, let's bring it to a close here. You've had so many different aspects to your career, Rubicon Founders, a lot of other companies that you've helped bring to market, policy architecture, a lot of things that have taken you to where you are now. If you could have gone into a different career path earlier in your career, took a left instead of a right, where would that have been? Is there a different aspect of curiosity and perhaps the theater, music, arts, bench science, something else that you could have gone into that you otherwise didn't?
I was a musical theater kid in high school, so I don't think I was quite good enough to make it. I don't think you would have seen me on Broadway. My accents are not very good, being very direct. I think for me, the path not taken is probably something in education space. I think there's a lot similar to healthcare where we need to advance the ball from where we are today. And in education, there's a lot of opportunity as well. But I have no regrets on the path that I have taken. I'm reminded of this every time I do a site visit and get to speak with patients and doctors who are participating in our models. I was out in actually a patient's home under our guide model recently.
Oh, wow.
And I got to sit there for an hour and a half with a doctor who's able to go in every other month and speak with this woman with dementia who's in her 90s and her daughter, who's her caregiver, who's elderly as well, and understand the risk of falls and understand how they're doing and understand if her daughter might burn out and how that might influence her care, and know that we are making a difference in terms of how care for this family is delivered, and that there are many patients across America, many people whose lives are made better by the efforts of people who have gone into healthcare and thought through, how can I make this situation better? And so whether it's home-based care, whether it's coordination, or whether it's new resources, people who have come in to go and help care for people in healthcare, which is not something that I anticipated doing, when I was a kid, didn't know much about the healthcare system. And I'm sure for many people, given just we're at 18% of GDP, that's a lot of people working in healthcare. This was not the path we envisioned, but we're really making a difference, and that's important.
I think that's a perfect note to end on, Abe, and a fascinating piece of maybe your background that has another chapter later in life in terms of impact to mass education, access, and innovation. So Abe Sutton, the director of CMMI and also the deputy administrator of CMS, thank you so much for joining our show today. It has been a pleasure to speak with you, my friend.
Thank you so much for having me on. It really was a privilege.